And this again will be an interactive case-based discussion. We'll be discussing two cases. One is diagnosing and managing pancreatic adenocarcinoma. The second will be managing complications of acute and chronic pancreatitis. Here's our very good-looking panel. Dr. Donahue, Dr. Muthusamy, Dr. Ross, Dr. Sedarat, and Wainberg, who I'll introduce individually as they come up to speak during the session. And again, it's interactive. So again, if you have questions that come up during the talks or the case presentation, please write them down. I'll take a look at them, and after the case has been presented, we'll go over your questions together. All right, so let's begin. So diagnosing and managing pancreatic adenocarcinoma. So the case is a 54-year-old healthy man who presents with painless jaundice. He's lost 15 pounds over the past 3 months, and his wife noticed that he had become jaundiced over the past week. He denies any medications or supplements, and his labs reveal elevated liver tests. His bilirubin is 8.9, his alkaline phosphatase is 357, AST and LT in the 200s. So you're an astute gastroenterologist, and you're suspicious for pancreas cancer. Which test would you order to make the diagnosis? Choices are CA19-9, CT abdomen pelvis, an MRCP, an endoscopic ultrasound, or an ERCP.
It's similar to this. I did.
All right, so half of the audience chose CT abdomen pelvis, and a third of the audience chose endoscopic ultrasound. A few stragglers here with CA19-9, MRCP, and ERCP. All right, to talk more about the diagnostic tests to detect pancreas cancer, Dr. Alireza Sedarat, one of our assistant clinical professors here at UCLA.
Good morning. Thanks, Stephen. All right, so diagnostic tests for pancreas cancer. So just a quick background. This is the most recent NIH data about pancreas cancer, 11th most common cancer, the 4th most common cause of cancer death, lifetime risk of 1.6%, and the median age of diagnosis at 70. Survival depends on stage, but 75% will die within a year. The 5-year overall survival is abysmal, although it's better for localized disease, and only 10% of patients, however, present at that localized disease, which is defined as either T1 or T2 with no nodal disease or metastasis. So the prompt diagnosis is essential. When to suspect someone has painless jaundice, weight loss, and abdominal pain. Recent diagnosis of diabetes is important. We're investigating this as well. Unexplained pancreatitis in an elderly patient, unexplained mass. Hereditary pancreatitis syndrome is important. A little pearl, if someone has chronic pancreatitis with an abrupt change, so they suddenly have weight loss, suddenly have pain, whereas before they were doing okay. Unexplained duct dilation and a stricture, particularly if there's downstream atrophy of the gland on imaging, that should be suspicious to you. So CT scan is probably what most people would reach for first because it also can look at other things. It has a pretty good sensitivity. It's best with multiphasic IV contrast. And there's excellent vascular staging when it's ordered as a pancreas protocol, meaning thinner cuts through the region of the pancreas. Larger tumors have higher sensitivity. So here's a recent case that we did at UCLA. You can see immediately that the biliary tree is very dilated, comes down to a point where there's this ill-defined lesion or mass hypoattenuating in the head. And this, I would say, is a somewhat typical CT scan with contrast to someone that has a suspected pancreas cancer at diagnosis. MRI is also available. For the most part, it's probably equivalent to CT for mass detection. It has primarily the additional advantage of evaluating the ductal anatomy, although in pancreas cancer, as opposed to, for example, bile duct cancer, that may not be necessarily crucial. It's a longer test and a more expensive test, so there may be some motion degrading if the patient can't stay still, and that can impair vascular staging. It may be useful if someone, for some reason, is allergic to iodinated contrast. That to me, is probably the main reason to reach for an MRI. ERCP really shouldn't be on the list of things to consider for diagnosis of pancreas cancer. It's more of a therapeutic modality nowadays, although, as you know, maybe 30 years ago it was used in diagnosis. Brushings can be performed, though its accuracy is less than other modalities. In terms of cancer diagnosis, primarily it's used if something and the suprapancreatic bile duct is affected or out of the reach of an FNA, or there's a suspicion of something that will need cholangioscopy with biopsies. That's where ERCP as a diagnostic modality will come into play. CA19-9, I don't think should be really used as a primary diagnostic tool, and I think if you're going to take anything away from this slide set, maybe take away to stop using that as a primary diagnostic tool. It probably adds more confusion than it needs to. It's most useful as a marker after you have a tissue diagnosis. It has low specificity. It is elevated in cholestatic benign diseases and other pancreaticobiliary diseases that are benign. And in addition, it requires this Lewis blood group antigen, which is absent in 5 to 10% of the population, so it's useless in some patients. Again, it's just useful primarily as a cutoff. However, if you have someone, particularly with a normal bilirubin and a very, very high CA19-9, that should at least raise suspicion a little bit, but it shouldn't be your primary diagnostic modality. EUS, when you're in doubt, the answer is EUS. Although I guess not on that one, maybe the answer should have been CT first. But its main utility is its ability to detect smaller tumors than CT or MRI. It allows for tissue diagnosis, which is highly accurate. Increasingly, we're able to reliably get core samples, which may be important in personalized medicine. Compared to percutaneous biopsy, EUS biopsy is less likely to cause needle tract seeding, which is important. And so I would say that in 2019, percutaneous biopsy of a pancreas mass should really be a historical phenomenon. It's not something that we should really be reaching for. If someone has a mass, if you don't have EUS available, you should be referring those patients elsewhere. So the other utility is that previously unsuspected distant metastases may be upstaged. So a smaller tumor in the liver can be detected, or ascites or a mediastinal node. It's our routine to look for these things when we're looking at a pancreas mass. And if we upstage a patient, that although it's maybe not great for them, it's good because they'll avoid unnecessary therapy or surgery. Here's an example of EUS FNA. There's a very ill-defined mass. Now this is the extent of my PowerPoint abilities, so there you go. There's a mass there, very ill-defined, very large. There's a needle going in to get a diagnosis. Here's another one. This patient had some abdominal pain and a mass. There's maybe a duct that's dilated there. And again, FNA is being performed, and fantastic PowerPoint skills there. And this is a really interesting patient. This is about a 14 or 15 millimeter sort of cystic ill-defined mass. This patient had jaundice and some pain, a dilated duct, and her imaging showed no mass. The read was actually concerning for a stone. And so this is kind of one example where US picked up something that the other imaging missed. And this patient went on to a robotic Whipple and did very well. There it is there. EUS, however, isn't perfect. There are scenarios where we sometimes don't know what we're looking at. Probably the hardest may be chronic pancreatitis. There's a lot of inflammatory changes, fibrotic changes, calcifications, a lot of artifact that can both mimic a mass and also obscure a mass. Same thing in acute pancreatitis. It can either obscure a mass or mimic a mass in acute inflammatory processes. There's also a phenomenon sometimes of a diffuse or infiltrative mass of pretty much the whole pancreas. It's rare, but aggressive form of the disease. And sometimes when we look at the pancreas, the whole thing looks the same, but the whole thing is a mass. And so sometimes that can be missed unless the suspicion is very high. Thanks.
All right, so Dr. Sedarat, so which one would you choose for this patient, given the history or the case that I've presented so far?
Yeah, so I think because it's an initial suspicion, my opinion is probably a CT scan with contrast is the best thing because it'll allow you to locate a mass. It'll allow you to, if there is a mass, get vascular staging. And also the other thing that we have to kind of be, I always tell people that you want a CT before you FNA something, because sometimes even subclinical pancreatitis can obscure vascular staging on imaging. So if they, for example, a mass was seen on transabdominal ultrasound, and then we go right to US and FNA it or do an ERCP, even if their patient's fine, there may be some inflammatory changes that can obscure subsequent CT imaging.
Any other thoughts from the panel?
So I agree 100%, and I think there's a couple of other issues just to add in here. Number one, EUS, other difficult scenarios for EUS is user variability, right? So there is certainly a learning curve, and there's certainly a higher sensitivity with more experienced users. And then, again, I think just the issues around making sure that you have cross-sectional imaging before you go forward with the endoscopic ultrasound. I always like to say that EUS is a great test to answer specific questions that were brought up by cross-sectional imaging, but it's not a great test for, oh, hey, Ali, I've got a patient who has abdominal pain. Can you do an EUS to make sure that they don't have anything in their pancreas? It's a much better test to answer a specific question like, does this mass involve the portal vein? And we can even argue about that.
No, that's a very, very good point.
Yeah, and I'd make two small points. One is, if your CT, I agree with CT as the first test, but what if your CT is normal or doesn't show anything? I think where we do know, even today, is that for sort of sub 2 centimeter and particularly sort of very small lesions, EUS is still the best detection test. So if you have a negative CT, but your clinical suspicion is still high, I would still suggest that you get an EUS after that, not just stop, say, well, the CT was negative. And the other thing, just to corroborate what Ali said about CA19-9, there's all kinds of things that can give you an elevated CA19-9. It turns out pulmonary fibrosis is one of them. Certain Ts can give you that. And chronic pancreatitis will usually run into between the 50 to 200 range. So if you get something that's like 100, there could be a lot of different things, and so it's better to track it in patients who had initially elevation than to use it as a screening test.
All right, thank you guys. So just by a show of hands in the audience, how many people perform endoscopic ultrasound here? I got 2. Great. And how many people perform ERCP? Wow. All right, so almost half. Okay. So I guess the point of the story is, I know that it was a suspicion for pancreas cancer, but the patient is jaundiced. We don't know what the cause was. Maybe start with cross-sectional imaging first, and if you see a mass, then proceed with the referral for an endoscopic ultrasound to either patients up on the panel here or the 2 gentlemen here in the audience. All right, so the case moves on. The CT reveals a 2.5 centimeter mass in the head of the pancreas with bile duct dilation. The mass appears to involve 180% of the SMV, or wrapped around 180% of the SMV. EUS with FNA is performed to confirm the tissue diagnosis of pancreas adenocarcinoma. ERCP with biliary stent placement is also performed. The patient follows up in clinic to discuss the results. He's read about pancreas cancer on the internet, and he found out the only chance of cure is if he can undergo surgery right now. That's what he's read. And he'd like to know if his cancer is resectable now. So, question to the audience. Should the patient undergo Whipple surgery based on what you've heard so far? Yes, no, or I don't know. Okay, well, just by show of hands, who says yes, the patient can get a Whipple now? 1. Who says no? Most of you guys. And who has no idea? Leave it to the surgeon to decide. A few of you guys want some honest answers. All right. So to discuss this question as well as the role of staging, assessing resectability, and surgical outcomes, the UCLA Experience, we have Dr. Tim Donahue, Department of Surgery, and the head of surgical oncology here at UCLA.
Thank you, Stephen. Thanks for asking me to come talk. I would have voted no, too, but I'm not given the option. Okay, so we talked about that pancreas cancer, number 4 cause of cancer-related deaths in this country right now. It's actually predicted to become the number 2 cause of cancer-related deaths within the next 5 to 10 years if the current incidence and survival trends continue. So it's going to be just behind lung cancer, big disease burden in this country. Most cancers of the pancreas develop in the head, not the body or tail. So you can see about 3/4 or 2/3 of the cancers occur within the head of the pancreas. It's where the greatest volume of pancreas is located. So it's important in terms of the local staging. As you know, the superior mesenteric artery and superior mesenteric vein course very close to the head of the pancreas. And so oftentimes the tumors grow just enough, which is, I don't know, a centimeter, 2 centimeters sometimes, to involve these two structures. And so local staging is really important. This is a slide put together by Matt Katz that I use all the time, but it's the clinical spectrum of resectability. You can see there on the left, that's the T is the tumor, clearly a resectable tumor that's not involving the vein or the artery, the V and the A, which we pay very close attention to when determining resectability or local staging. Next, we start talking about borderline resectable, which just involves part of the superior mesenteric vein or artery. And you can see this tumor here has grown to involve both a part of the artery and part of the vein. And then unresectable or locally advanced are tumors that have grown to involve a significantly larger portion of these vascular structures, which cannot be resected without being reconstructed, particularly the artery, although we're challenging that paradigm now too. Nobody really agrees with what borderline resectable means, so you can see that there's an NCCN definition, HPBA definition, MD Anderson has their own, of course, ISGPS definition, an ACTO definition. I'm sure there's some gastroenterology definition too that may be added to this table, but highly variable. Staging for pancreas cancer, it's recently changed this year. There's a new AJCC staging system that involves N1 and N2, which is new. There used to just be an N1 or N0, but they've found some prognostic significance in having an N2 category. And the T stage of the pancreas has changed also. It used to just be if it was T3 extended outside the pancreas, but now it's purely size based. So if you're doing some preoperative staging with endoscopic ultrasound, all two of you out there, just be aware of the new staging system for pancreatic cancer. We talked about borderline resectable, which involve part of the blood vessels, and then locally advanced, which involve more of the blood vessels. The treatment paradigm or sequence for these patients is usually they're staged, and then rather than brought to surgery initially, they're given chemotherapy to try and shrink the tumor such that no vascular work is necessary and to make sure that what they really need is a local therapy, potentially radiation at some centers, although we don't really use it at UCLA too much. And then more staging and then surgery. But you can see down there that the patients who are diagnosed with borderline resectable disease, 42 to 65% of them wind up undergoing an operation. So a majority undergo surgery if they have borderline resectable disease. Locally advanced is the disease that involves more of those blood vessels that are around there. And oftentimes patients are in this endless cycle where they get staged and they get chemo, then they get restaged, and then they either go to surgery or get radiated or get more chemo. But for the most part, these patients are treated for longer. About 28% resection rate as an estimate, so lower than the borderline resectable cases. And I think this is important just as a rough number to know when counseling patients at their time of diagnosis. So just in summary, locally advanced borderline resectable disease, resection rate for borderline resectable 50 to 65%, locally advanced 25 to 30%, so lower. And you can see the incidence or the rate about across studies of the R0 or margin negative resection rate. We recently, Steve asked me to talk about UCLA Experience. You want me to talk about UCLA Experience a little bit? Okay, so we recently, we have an exchange program with the Japanese Hepatopancreaticobiliary Society, and they always send us over these really great junior faculty and fellows. And this is a recent study that one of them did, which is why it's UCLA Mayo Clinic and Tohoku University in Japan, but looked at the importance of margin negative resection in patients who had received preoperative therapy for pancreas cancer, right? So there's a lot of other prognostic markers like lymph nodes or histopathologic response to treatment. But basically what he found is that margin negativity is still very important, right? So we need to, as best we can, try and accurately stage these patients and determine whether or not they're going to be able to undergo a margin negative resection. One of the tests that we use to do that really is CA19-9. We think it's a really great marker in response to therapy or the amount of tumor burden. in patients. And you can see this is a study that we did at UCLA where we show that if we treat patients for longer before surgery, they do better, and we've treated them. But those patients who had a normalization of their CA19-9 had markedly longer survival than those whose CA19-9 didn't normalize. So it's a metric that we use and follow to determine when patients with borderline resectable or locally advanced disease, I didn't say which, but when they are candidates for surgery. We like to try and give them a full 6 months of therapy before surgery, unless their marker normalizes, and then we take them to surgery and save some of that treatment for after the operation. So in conclusion, the staging, assessing, and resectability outcomes for patients with pancreas cancer, there's a new 8th edition AJCC. The T stage has changed, the N stage has changed, and it's thought to be more reproducible, discriminatory, and in line with other GI cancers. Borderline resectable, locally advanced disease, they involve that local vasculature. Oftentimes there's debate about how to manage these patients at multidisciplinary tumor boards. But in general, they should be treated with chemotherapy, maybe radiation therapy before surgery. And it's important to try and restage them after treatment to make sure that they can have a margin negative resection, because that's an important predictor of survival in the US and apparently in Japan too. And CA19-9 is a really good predictor of how those patients are responding to treatment and their ultimate prognosis and how they will do. So great, thank you very much.
So I think Dr. Donahue already answered this question, but he said no, he would not recommend Whipple surgery now. But for the purpose of the case, let's just say he was taking the OR, maps seem to invade the SMV, portal vein, and the SMA, resection is aborted. He's then referred to oncology for further management. The patient calls to ask what to do next. So what are the treatment options for pancreas cancer? A, radiofrequency ablation, B, cryosurgery, C, chemotherapy, D, radiation, or E, both. And Dr. Donahue alluded to some of these things, but let's see what you guys choose. All right. So to further talk about this topic, we have Dr. Zev Wainberg, who's going to talk about the chemoradiation options to treat pancreas cancer. He's an associate professor of medicine here at UCLA and the co-director of the UCLA GI Oncology program.
Thank you. Thanks, Stephen, and thanks, everyone, for inviting me. So when we think about resectability, as we've already gone over, we can really characterize tumors into resectable versus the other extreme, which is distant metastatic disease. And then we've realized there's a whole lot of diseases that are in the middle. Pancreas cancer is unique that way in some respects, that there's a lot of variability, there's some subjectivity in terms of how much the vasculature is involved. So a lot of patients get clumped up into this middle category. Up to 60% of patients are neither clearly resectable often or metastatic disease. And so there's been efforts to try to characterize these patients better. Tim showed this case here of resectable. We think roughly, if you look at the literature, about 20% of patients, only about 20% are purely resectable, whereas 40 to 50% of patients would be considered locally advanced or categorized as borderline, which unresectable is certainly part of that group, whereas another 40% of patients present with de novo metastatic disease. And so determining what to do in patients who have localized therapy has been the subject of many, many years of controversial research between combination chemotherapy, radiation therapy. By and large, most of the data, and I think, we don't have a radiation oncologist on this panel who might slightly disagree with this, but I would say by and large, most of the data supports a combination chemotherapy approach for patients who have been resected, as I'll talk about in a minute, or unresectable, whereas there is certainly some data to support, though, radiation as well in certain contexts. So as background, these are some of the largest clinical trials that have been done historically in the last number of years in pancreatic cancer. And they've been in several groups, primarily in either out of Germany, which has been leading the CONCO trials, and then the United States with the SPAC group. And the rough survival numbers that we quote patients who have resectable disease is 2 years. So that's a median number of survival of someone who has purely resectable disease, the best case scenario. The median historically was 2 years. Metastatic disease, of course, with the advent of modern combination chemotherapy, the expected survival is about 11 months with FOLFIRINOX, and in the Gem-Nab paclitaxel or Abraxane study, they had an 8.5 median survival. So even in the group that was purely resectable, historically, the survival expectations historically were not much beyond 2 years. Now that has changed, as I'll show you in a little bit, and that has left us with, in some respects, options over how to treat patients in the adjuvant setting. So these are some of the options that historically have been used. A lot of Americans had followed the JITSIG trial design, which looked at 5-FU-based chemoradiation with fractionated radiation over a period of about 6 weeks with about 55 or gray or so to the bed of the pancreas along with infusional 5-FU or oral capecitabine. Some other trials looked at incorporating gemcitabine along with the radiation and alternating the chemotherapy regimens. And then in Europe, a number of studies have been done, which Europe does not use radiation therapy very much for pancreatic cancer. In very rare circumstances, actually, do they radiate pancreatic cancer in Europe, and they've historically treated patients with adjuvant chemotherapy alone. So radiation therapy, I'll spend a few minutes because there's, again, to be fair and balanced here, the right kind of fair and balanced does not exclude radiation oncology completely from this equation. There is a role for radiation oncology, and I've listed here what I think the role is. And I did run this by one of our radiation doctors, and they're in agreement. So there are defined goals over where radiation has a role here. One is in purely resectable disease, maybe in the post-operative setting to decrease the local recurrence rate. And those particularly on patients with high risk of local recurrence. And I'm going to say that's where Tim just showed N2 or above is where there is data to suggest, okay, if you have a patient with a bunch of lymph nodes, the risk not just of metastatic disease, but the risk of local recurrence is sufficiently high that you can look at the subset analyses of a lot of these studies and demonstrate certainly that local radiation to the bed of the pancreas after a Whipple surgery or after a distal has led to reduction in local recurrence, which is a huge cause of morbidity in our patients who have a local recurrence. The second area in which we do use radiation is in borderline. As Tim just showed you, there's some data that this is a clearly defined category, distinct from locally advanced, in which there's a high rate of resectability. And if we're not quite there with chemotherapy, we do sometimes incorporate radiation to the pancreas in an effort to make them resectable. And by that I mean, particularly with SBRT, which is nowadays the preferred radiation approach for these patients, there is good data to show that if patients aren't quite resectable after chemotherapy and there's still a suspicion that the patient will have an R1 resection, you can go ahead and do SBRT and convert some of these patients to resectable. And the final role for radiation is in patients who are simply never going to obtain an operation, and it's really done for palliation. And the true risk of resectability there is low in most of these patients with locally advanced disease, but radiation does have a role to minimize local obstruction and pain. But by and large, and this came out in New England Journal of Medicine last year, the landscape has changed, primarily led by the French group, which has done, the Prodige group has done probably the biggest clinical trials in the last number of years in pancreatic cancer around the world, randomized phase 3 clinical trials. And in this study that was presented last year at ASCO and is going to be published in New England Journal, or was just published, I should say, randomized patients with R0 or R1 resected pancreatic cancer to old chemotherapy, gemcitabine alone, to modern chemotherapy, which is modified FOLFIRINOX, which is by and large what we have been using for metastatic disease. And these patients all had a resection in an academic center in France, so we have to take this with a grain of salt. And they did two interesting things in the study. Before they randomized them, they excluded all of the patients with an elevated CA19-9 above 90. So they really looked to exclude as many bad actors as possible. And by that I mean that these were patients who were the creme de la creme, so to speak. They underwent a full resection of a Whipple or a distal, and then they were randomized with an R0 or R1 resection to receive full chemotherapy. And again, they excluded some patients, and this to me is very important, and how you design clinical trials and how you try to eliminate the patients who already have microscopic metastatic disease. And in doing so, they basically excluded patients who had elevated tumor marker greater than 180, and that's already taken out a subgroup of patients that we know is not going to have the best long-term outcomes. But needless to say, they did the primary endpoint of the study was twofold: median disease-free survival and I'll show you in a minute, median overall survival. So you can see here, disease-free survival simply means, as we all know, the absence of any disease by imaging, and the differences were quite good. There was a 21.6-month median versus a 12-month median with gemcitabine, and 3-year disease-free survival was about 40%, which was considerably higher than has ever been reported in the literature. And when they looked at what were the prognostic factors for this disease-free survival, in multivariate analysis, a couple of things came out, and one of them was certainly the group of patients who got the aggressive combination chemotherapy approach. The other thing that came out was grade. The patients who had had a poorly differentiated tumor had a higher risk of recurrence, and those who had portal vein resection had a higher risk of recurrence. Now, they looked at several interesting other endpoints, which one of them has never been used in oncology literature that much for pancreatic cancer, and this wasn't disease-free survival, this was metastasis-free survival, which basically looks at patients who have no metastatic disease, just local recurrence. And here, too, there's a huge difference in the group of patients who received FOLFIRINOX versus gemcitabine alone. And then finally, which is the ultimate arbiter of success in our business, is overall survival. And in this respect, it was very clear that there was a huge difference in the group of patients who received FOLFIRINOX versus gemcitabine after surgery. And the 3-year overall survival rate was significantly greater, with 63%. That's never been shown in pancreatic cancer before. And a lot of people have, say this is hard to believe that the median overall survival of this group of patients is 55 months. 55 months is 5 years. So that's almost some of these patients, as you can see here at the end of the curve, are being cured with pancreatic cancer. And the reason that was shown is that there is crossover, and there is separation of the curves very early in the study. At about 2 years, what happens is the group of patients who got FOLFIRINOX really separated themselves from the other group of patients, which is very consistent with what we see in oncology trials when you have a very active therapy compared to a subactive therapy. So this was a huge leap forward, and in many respects has replaced everything else for patients with pancreatic cancer chemotherapy-wise. We now regard patients that can handle it, all of them should get modified FOLFIRINOX, in my opinion, based on this data. Again, those who can handle it, and that's a subjective thing, and it's certainly not right for most patients. But in those, based on this study, that has now become the de facto standard of care. Now, the bigger question that the field is going in, and this is moving the point that the case that Stephen brought up even a step further, is even if you have resectable disease, maybe we should be giving all of these patients chemotherapy before surgery. And that's been the subject of a lot of people's work these last few years. And at UCLA, we're doing a lot of studies looking at that question: is can you even treat pancreas cancer the way we treat gastric cancer, which is, by and large, even patients, many of them, studies have shown, including the MAGIC trial and more recent trials, that if you have a patient with resectable gastric cancer, maybe you're better off treating the patient neoadjuvantly and giving them some chemotherapy before the operation, and then staggering the operation in between the cycles of chemo. And the reason that's logical in pancreas cancer is obvious, is that many of these patients will relapse very quickly after a surgery, and we all see that all the time. So there have been some studies looking at this. Another one that came out of France was pretty good, I thought, that was asking this question in a bit of a roundabout way, in which they took patients who were either resectable or borderline resectable in the French cooperative group, and they randomized them to either surgery followed by GEM, so substandard chemo. Keep in mind this FOLFIRINOX data just literally came out in the last 6 months, so gemcitabine was one of the standards until that. to gemcitabine, then followed by radiation, and then a little more gemcitabine, then surgery, and then more chemo. So taking patients, a lot of them who are purely resectable, and asking the question, can you go ahead and give them neoadjuvant chemotherapy and improve outcomes? The resection rate, first of all, there were a number of endpoints in the study. One of them was how many patients had an R0 resection. You could see the group of patients who had an R0 resection, even in patients who the majority of them were felt to be resectable by imaging, was still only about 30% who had surgery right away versus about 63% who had some neoadjuvant treatment. So already that's one endpoint that we feel is being improved. And then if you look at the overall survival in the intent to treat patient population, you did see the group of patients who got some neoadjuvant therapies living longer and delaying at least the rates of both preoperatively and post-resection. The ability of patients who went to an operation was significantly survival improved in the group of patients who had some preoperative treatment. So the results of this do demonstrate, and this was a bit underpowered, it was a randomized phase 2 study, so it wasn't a randomized phase 3, which is our gold standard, but it certainly did suggest that even in resectable patients, moving the chemotherapy up front has value in producing long-term outcomes. And that makes sense in some ways, because when you think about this disease, we know that even some group of these patients who have resectable disease from the beginning already have metastatic disease. And microscopic metastatic disease is simply not detectable by either tumor marker or imaging, and those patients are going to relapse. So these are the standard approaches, and you could see that neoadjuvant treatment may be better than adjuvant treatment in the majority of patients for the reasons I described. So I personally think that this field is moving quickly to a neoadjuvant approach in all patients with pancreatic cancer, and that's kind of the way gastric cancer happened years ago. And I suspect, if this trend continues, that in a few years from now, we'll be treating every patient with pancreatic cancer up front with chemotherapy for at least 3 months to both provide a biological filter that patient's not going to metastasize in the short term, and also in the patients who have a questionable margin as to whether it'll have an R1 resection, reduce that number significantly. So I think, I don't know how many years from now, but a number of years from now, we'll be treating all patients with pancreatic cancer up front. So thank you for your attention.
All right, thank you, Dr. Wainberg. All right, so we're going to go back to the case here. So despite receiving treatment for 3 months, imaging shows no significant improvement in his tumor. He's now due for his biliary stent exchange. And now many guys do ERCP in this room. What type of biliary stent would you place in this patient? A, plastic, B, a fully covered metal, C, partially covered metal, or D, uncovered metal? All right. So half the audience chose a fully covered metal stent, and some of the other choices were also somewhat selected. So to speak more on this topic, as well as the endoscopic palliation of pancreas cancer, we had the director of endoscopy at UCLA, the course director for the Mellinkoff course, and my boss, Dr. Muthusamy.
Thank you, Stephen. So I'm going to try to take Andy's lead and talk, basically give you the answers here. I've sort of provided the background details here, but for the instance of time here, I'm just going to try to get to the summary take-home points. So I've sort of put in sort of large letters here because treatment of biliary obstruction, because that's the major palliative thing we do endoscopically in patients with pancreas cancer. You just heard that 3/4 of the patients usually have lesions involving the head, and that only about 20% or less will actually be resectable at the time of diagnosis, and maybe even that's going to drop as almost everybody gets treated up front. So you're going to have to decompress most of these patients. So the question is, how do you do that? The other things that I'm going to talk about briefly are what if you get duodenal obstruction and management of pain with celiac blocks. I'm not going to talk about EOS applications for treatment, which include placing fiducials for image-guided radiation therapy or direct injection of anti-tumor medications or brachytherapy seeds. Okay, so the questions that you just asked were plastic versus metal, metal what type, and alternative approaches if standard access fails. So So the answer here is, I don't know what your musical tastes are, but you should, when it comes to biliary stenting, you should learn to love metal, any type of metal, because the answer is metal stents are better than plastic, and there's no real difference between which choice of metal stent. So that's the answer. So plastic stents, again, you see are obviously much cheaper. You've got covered, partially covered, fully covered stents. Advantages of plastic stents, they're fairly cheap depending on your contract, $50 to $100. They're removable, they're smaller diameter. Typically we place 10 French stents, but that has reduced patency. We actually published a paper a few years ago with our colleagues at Northwestern that showed that when you're getting preoperative chemotherapy, 10 French or larger stents, even though they typically manufacturer recommendation is that you can go up to 12 weeks, the median patency was only about 7. So you have significant shortening, which obviously means admissions, delays in care, admissions for cholangitis and so forth. There's low risk for stent migration and cystic duct obstruction. Metal stents, of course, are more expensive. Some of them are removable, obviously, if they're fully or partially covered. They have larger diameters, usually 10 millimeters, prolonged patency, but there are some concerns regarding migration and cystic duct occlusion with these devices. So you've got 3 scenarios. You heard about the categories: resectable, borderline resectable, metastatic inoperable. Which one should I use for what? So let's start about resectable. So the short answer here, there's a randomized trial from Asia looking at this, and basically it showed that there was really no differences whether you did plastic or metal. Again, most of these people, though, only needed 2 weeks of drainage time before they went to surgery. So if you are fortunate enough to get these patients, which you just heard are a few and far between, and may even drop further if we're going to treat even resectable patients before, if you do get these plastic, but this is probably the only time you're going to use plastic stents in these situations. So what about everybody else? Meta-analysis of plastic versus metal stents for malignant bile duct obstruction. This is almost 1,700 patients, including 20 randomized trials. And looking at this, basically the cliff notes are that stent patency favors metal stents by about 5 months, 4.5 months. There's no difference in patient survival. There are fewer late complications with regards to cholangitis or obstruction. And there even appeared to be a small survival advantage for uncovered stents compared to the others. Maybe that's related to issues of obstruction of the cystic duct or not, we're not sure. Quality of life is improved with self-expanding metal stents, better physical and emotional function, less fatigue, nausea, vomiting, reduction of appetite. And they concluded in this study that in malignant extrahepatic obstruction, SEMS placement results in better scores for general and disease-specific health-related quality of life compared to plastic. What about cost effectiveness? I just told you that plastic stents are 1/10 or less the price. But the short answer here is there's 2 studies that have looked at this issue, and there's no difference in cost at 1 year between the 2. And the reason is you're going to do more ERCPs with a plastic stent, and if you even do 1 less ERCP, you've paid off your stent, right? So if you do a metal. So that's how it sort of comes out. So I'm not necessarily saying that it's cheaper to use a plastic stent, but overall it averages out with regards to this, and it's probably better for the patient to have fewer interventions. So there's increased short-term costs with SEMS offset by need for reintervention. Okay, so basically metal for virtually everything with regard, except for the immediately resectable patient. So if metal, which type? So again, there's several meta-analyses of this as well. And again, this is comparing different types of stents, and there was no difference in patency at 6 or 12 months between the types. The covered SEMS were associated with higher migration rates, which you'd expect since there's no anchoring component. They have lower ingrowth, which again you'd expect because they're covered, but they tend to have more overgrowth. So you may not have as much growth, but you have more things that slide out, more things that get overgrown. In the end, it turns out to be about a wash. 2 other studies have looked at this. Again, this has been well studied, 1,500, 2,200 patients in these studies. No difference in patient survival, adverse events, or overall patency period. So basically, the short answer from these is that it really doesn't matter. In patients, there is a risk for migration. You see the migration rate for fully covered stents is somewhere between 2 and 12 or 13%. The cholecystitis rate is usually in the single digits. Typically, we recommend using the shortest stent possible. Remember, a 4-millimeter stent is 4 millimeters in open air. In a tight stricture, it's going to be slightly longer than that, so I mostly place 10-4s. I try to keep it below the cystic duct if I can. I tend to use either fully or partially covered. In patients who are unresectable, I tend to use uncovered stents only because there's no difference, and if there's no issue, with regards to removal by the surgeon, then why not just put in an uncovered and you don't have to worry about it. So only reason I put in sort of fully covered stents is because it's easier for Tim potentially to remove these in the operating room. We can talk to him about that. So what does the NCCN tell you to do? Basically what I just said, placement of stent, preferably short metal stent in patients who are getting planned neoadjuvant therapy. Locally advanced, same. And they specifically say a short metal stent, but they didn't tell you which type because, frankly, it doesn't matter. So here's the answers. Resectable patients, plastic stent versus no pre-op drainage. If you live in Europe, which it seems to be, that seems to be the answer. Metal stents, discuss with your surgeon regarding stent type. We typically place fully covered for patients who are borderline locally advanced who may end up getting resected. And then if they're obviously inoperable, I tend to place an uncovered stent. Okay, alternative approaches. What if you do an ERCP and you can't get in? You can do EUS to facilitate ERCP, and you can hopefully avoid the need for interventional radiology. So we can do direct EUS-guided rendezvous instead of having the interventional radiologist do it. We can do it ourselves, or we can do an EUS-directed creasement of a fistula, choledochoduodenostomy, hepaticogastrostomy, and so forth as well. So this is EUS rendezvous. This is a series that we did at Irvine several years ago. Basically, you access the duct, you get the wire down. The hardest part is getting the wire, instead of going up the duct, to go down out the papilla, but once you do that, you can usually grab it or actually just even cannulate next to it and then sort of place the stent the normal way. And by doing this in patients with failed biliary cannulation, we were able to salvage about 3/4 of those patients. This is a video courtesy of Dr. Janak Shah at New Orleans. At the Oshner Clinic, and basically this is a patient who has a totally, good luck finding the papilla there in that lesion. So he's actually sort of come in from sort of on the right side, he's actually using an antegrade approach where you can basically put a wire down. This is basically an internal IR procedure where you just basically put the wire down across the papilla, and then you can do a stent placement. On the left, he was successful in getting the wire across, and then now you can see the hole, grab it, and then place a stent in the usual fashion. So the point is that EUS can salvage cases that you might not typically be able to do with standard ERCP techniques. So again, you can create your own, you can do an EUS-guided choledochoduodenostomy, just put a wire into the bile duct and then put in a covered stent, and or you could even drain it directly across from the liver. This is basically placing a stent from basically the intrahepatics across the stomach into the liver and draining it that way. So this is, again, these have been associated with technical success rates of 90 to 95%. Somewhat lower clinical success rates and adverse events rates of 10 to 20%, bile leak probably being the biggest issue. So you can see in the video on the right, just couldn't get that wire across the opening very well, and so in the end it was placed, a plastic stent was placed across the stomach. So the last one, which I think is probably the way this is going to go, is lumen-opposing stents. These are actually approved for use in Europe, not yet in the United States. These are the same. We're going to talk about this in the next session on benign disease, but this is an off-label indication at this point, but I need to mention that. But this is, again, this is a dilated bile duct, and you don't actually even potentially need a wire if the duct is big enough. You could put one through. But again, you can see a wire going up. It doesn't matter which direction here. You need about 15 to 20 millimeter duct, and then you can basically place this lumen opposing stent, then pull it back, and then deploy the other stent flange inside of the duodenum here, and now you've got a direct sort of choledochoduodenal fistula. You're looking right up the bile duct there. There's some thought that to enhance patency, you may place a plastic stent through that to do that, so to maintain patency. This is a study that we did a couple of years ago, basically highlighting the fact that people who can do EUS and ERCP are able to sort of relieve these obstructions better. At the top, you see the first column is the people who could do both. People on the right could only do pre-cut. That was their skill set. And you can see at the initial session there was a statistically significant difference in success, 95% versus 75%, and overall that about a 15% increase in overall drainage success. And this was particularly true for malignant obstruction. Benign strictures, they were both successful. So it's really hard. Benign disease, it's easier to pre-cut your way in. It's harder to do that in malignant disease. Last, EUS shows that the data is very good compared to percutaneous disease percutaneous biliary drainage, no difference in technical success, no difference in length of stay. EUS-guided drainage, though, improved clinical success rates, lower adverse events, fewer reinterventions, and was more cost-effective. So briefly, I'll just finish up talking about duodenal obstruction. This is the standard technique that we use. We usually use between 60 or 120 millimeter stents, usually 22 millimeters in diameter, that basically traverse these lesions. They can be placed overlapping. You can create essentially stent the entire duodenal C-loop if necessary. And so this has been our tried and true approach. This is sort of a study that, a systematic review of 44 publications of 1,046 patients comparing medical versus surgical therapy. There was no difference in technical success, early or late complications, or persistent symptoms, but there were more recurrent obstructive symptoms after sort of stent placement, 18% versus 1%. Surgical, of course, had longer hospital stays. But so in short, stents are better in patients with relatively short life expectancy. A gastrojejunostomy may be preferable in patients with prolonged prognosis. Now, we've traditionally used the word gastrojejunostomy as a surgical procedure, but it turns out that we can probably do this now endoscopically as well. This was initially described in a porcine model about 7 years ago, and now has been done clinically with a technical success rates of 90%, clinical success rates of around 85 to 92%. And one large study looking at 93 patients, multi-center retrospective, showed that similar clinical success rates to surgery. They had a higher technical success rate, though, in the surgical group. So you may not always be able to do this, and obviously the risk of doing this is getting a perforation, peritonitis, or bleeding. So one advantage of this is that you're not stenting through tumor, and maybe that would increase your patency. Lastly, celiac plexus neurolysis. Again, this is typically done, easy access for us, just below the diaphragm, below the GE junction. Often can see ganglia. This is where the transmission of pain from the pancreas by the abdominal viscera occurs. We usually use bupivacaine and alcohol, which is neurolysis. The effectiveness is 65 to 95%, but again, the definition of effectiveness varies. Some studies say it's as little as a 2-point drop in pain. You can get transient diarrhea, orthostatic changes, or even a short-term increase in pain. Serious adverse events, particularly issues like paralysis, are extremely rare. So again, the advantages of EUS I mentioned are safety and direct visualization. If you're able to identify ganglia, you're 15 times more likely to respond to the treatment compared to a bilateral injection. And a meta-analysis of 6 studies shows that bilateral injection is better than unilateral approach with regards to long-term need for anesthesia, analgesics. So in the future, and this isn't necessarily even the future, you could probably do this today. You could do an EUS procedure to get tissue acquisition. You could potentially do portal venous sampling to sort of look for circulating tumor cells to provide additional staging. You could do EUS-guided biliary drainage, as I just showed you. You could do an EUS-guided duodenal diversion if necessary. You could do a celiac block, place the fiducials, and even start the therapy on. This is all probably could be done in 90 minutes. And frankly, every one of the things I've said, I think probably many of us on this panel have done. So it's not pie in the sky. So in conclusion, use of metal stents for malignant biliary obstruction appears to be preferable except for resectable patients. Choice of stent, again, is unclear, but really probably doesn't matter. Probably should be done in consultation with your surgeon. Biliary access can be improved by EUS techniques and should be used when possible. Duodenal stenting is effective in the short term, but not as effective as surgical GJ in the long term. And again, endoscopic GJ may be an option in the future. And I think celiac neurolysis, especially when you can find a ganglia, is helpful. Thank you.